Chapman, welcome to our STED Talk, Spine Technology Education Discovery, March 2nd, 2022. These are eventful and difficult days, but we still have a job to do, and that is taking care of patients with spine problems. And we have an interesting program today. We welcome Professor Dr. Tariq Sohail from Lahore and his great team. He's the president of the Pakistan Spine Society, and I was personally able to see his great work. More introductions later. We've concocted a number of cases surrounding myelopathy, and that includes not just our usual great fellows, but we have one of my orthopedic spine surgery colleagues from Swedish here, Dr. Alexis Falikov, who is so kind to join us with an interesting case. So as always, we'll start off with some cases for discussion, and that includes obviously Professor Tariq Sohail, who is live with us together with his team from Pakistan. So Alexis, please come up front.
Thank you for having me here. My name is Dr. Alexis Falikov. I'm a spine surgeon here at Swedish Medical Center. I actually did my fellowship up in Vancouver, British Columbia, at one of their combined neuro-spine, the neuro-ortho spine fellowships. So I just wanted to present a kind of an interesting case. This patient is, let's see if we can do this on. All right, there we go. So this patient is SL. She is 79 years old, and basically about 2 months ago, sort of beginning of January, she developed this sudden onset pain into her left groin. She'd had some pain in the right groin for several years. Her past medical history is very mild for her. She has some dyspnea and exertion that she's had for the last several months that they've been trying to figure out where it's coming from. And it hasn't been that limiting, but it's been causing some troubles with ambulation. She's had arthritis in both knees. Her right knee's been replaced, and she has known arthritis in her right hip. This is an X-ray from last year. For those that are neurosurgeons, if you look right here, that is a worn out hip on the right side, but if you look her left side, it doesn't look that bad. You will notice that she does actually have a little bit of a scoliosis starting to develop over there. So basically in January, she developed this sudden pain in her left groin. It went to the upper part of her thigh. She rated the pain to somewhere between a 3 or 8 out of 10. When she was lying down, it was a 3. When she was up and walking, it was an 8 out of 10. She had no numbness. She had no weakness. And when she was standing or walking, it became much worse. She came in to see one of our orthopedic colleagues, physiatrists, who got some plain films. This is the more current film, and you can see really not really different compared to the films from last year. Still has arthritis on the right hip, but the left hip didn't look that bad. There's no evidence of any kind of avascular necrosis. Doesn't seem to be any kind of a fracture. We also got x-rays of her lumbar spine. You can see she does have a degenerative scoliosis, focused much more in the lower lumbar spine. So she does have a little bit of a curve off to the right-hand side at the lower aspect. You'll notice also she does have a little bit of a loss of the normal lordosis. She has some degeneration in the lower part, but the upper part of the spine looked quite good. So at the time, she was diagnosed with likely a hip pathology. So in the clinic, she had an ultrasound-guided injection to her left hip. She described about 30% relief. What's interesting is she didn't get much relief from the local anesthetic. She described that 30% relief over the next few days. She was sent back home, and 2 weeks later, she was continuing to have severe pain in that left groin area. She was describing the pain now as a 9 or a 10 out of 10. She couldn't stand for more than a few seconds. Her husband, who's about the same age as her, was having to pick her up to carry her to the bathroom. She had no saddle anesthesia, and she actually described no weakness. She said you could move her legs around just fine, but mostly she was confined to the bed. So at that point, an MRI was ordered, thinking that she probably had something since in the groin around the L1, L2 area. And this is the MRI scan that was obtained. It's a little bit dark. First of all, she has a autofusion between L4 and L5. But you'll notice that right up here between T12 and L1, so 5, 4, 3, 2, 1, between T12 and L1, you'll see there's this disc herniation there, and that it extends out. It's a quite large disc herniation, that level, and coming out all the way there.
More axials? Sorry for interrupting. Do you have an axial?
Yeah, that's the next shots. So more interesting, however, is the axial scans. So these are the axial scans. So what I did was I kept the scans from above and below, and you'll notice that you can see a very nice delineation of the dura. You can see over here, here is the bottom part of the spinal cord and conus. And as you can see, as we're moving down, it starts deviating out to the side, and you see something inside the dura on that side. And if you follow it down, you actually can see the rupture in the annulus right there. This is the entire conus being pushed off to the side. You can see this material inside the canal. And then down below, you can see the continuation of the cauda equina and the conus over there.
And bowel bladder function and hyperreflexia?
She actually had no dysfunction on her bladder. It was a little bit hard to tell. She had been given some narcotics, so she was having some retention, and she was having a little bit of constipation, but she was still able to go to the bathroom. I actually was scheduled to see her in my clinic, and she actually couldn't come into the clinic. Her husband just could not pick her up and couldn't bring her in. So we actually just had her brought in. This was, again, with her history of the dyspnea, there was always a small risk this could be some sort of intradural tumor. But I think part of the interesting one is if you go and look back, if you look, you can actually see that this is very continuous with the disc at this side. So it appeared to be an intradural disc herniation. And it's one of those things we just don't see a lot of them.
Yeah, do you want to take this at UCLA? Have you seen disc herniations, and did you see them in terms of this variant, intradural? Here, I'll bring you a microphone. So intradural thoracic disc herniation, conus area?
Well, we definitely said disc herniations. Intradural is obviously a little bit more rare. I think I saw maybe 1 or 2 during residency. It's a very rare pathology.
Anyone else, Zach? No, this does not work.
I saw 1 during residency, intradural, and I think the resident was going to write it up as a case report.
So these are pretty rare. Surgical treatment?
Same here.
How, go again over the details, Alexis, if you will. What tipped you off? Did you know this was intradural beforehand?
Yeah.
What tipped you off that this was intradural? Shows again with a cursor, if you will.
So a couple of things that led us to that. First of all, you can actually see most of the time, again, if you look, you can actually see the very nice border all around. You can see the outline of the dura, and you can actually see that it is not displacing the fat. So this, whatever is inside, is being contained by the outer layer. So obviously it's something inside the dura. And as you follow it down, you'll see, you can always see the borders of the dura. It's not expanded out. So that keys you, number one, that it is that. The second thing you can also see is if you just look, and I just kept the key images to make it, so this is just above, you can see here's the bottom port and the conus of the spinal cord being deviated over to the side, and you can see it completely pressed over to the side over there. And all of these things do suggest that it's an intradural. If you look very closely, you can see there's a tiny extradural component on the bottom left image right there. There's a very, very small sort of piece. And again, going back, if you look at the images, you can also see right over there that there is a small piece going over. And if you look, there's a contained, so you can see the border of the dura there. There's still a small fragment, still extradural. So it was an interesting one that you can see. And part of the key when I was sort of, again, all the way back to fellowship was if you see a nice distinct border of the dura on the outside, it really suggests that whatever the pathology is, it's an intradural pathology.
So great case. Did you get a CT?
I did not get a CT on her. On this one, from her point of view, she barely could move. And I actually didn't think it was really necessary. I think the hardest thing that we were trying to figure out was there's always a small chance that, again, because intradural disc herniations are so rare. I mean, if you think about, we move dura all the time, to have something come out and actually go through the dura, it requires sort of a combination of bad luck and an enormous amount of force. The other question was, could this be some sort of intradural tumor? Was really the sort of option. It really does not look like it. It's so focally contained. It is actually displacing the cauda. But it was one of the things that we always had in the differential.
And so what intradural tumors, Nathan, would we think of?
The first in this location would be a schwannoma. A ependymoma is always possible as well. Those would be the two things, a meninge, although this does not look like a meningioma. Those would be the three.
Great.
What'd you say?
And the only reason, so you said pressure would be one cause of this. I think erosion from a syndesmophyte, an ossified syndesmophyte would be another option that creates a weak spot in the dura. But obviously it's a clear surgical indication. Dr. Sohail, would you, I think we all agree surgery, any specific thoughts from your end? Have you seen intradural thoracic disc herniations and what would you do? All right, we have a connection.
Thank you. I have not come across, but I think even if there is osteophyte formation there, and then it's very unlikely that osteophytic dried up or degenerative disc would prolapse with so much force that it will, tear through the, dura and come into the intradural extension. To me, it more looks like a tumor rather than intradisc, medullary herniation.
Yeah. Yeah, he didn't do a full MRI, a neural axis MRI, right? You're pretty sure about the
Yeah, this scan actually went up to about T7. So luckily when they did the MRI scan, the radiologist realized that this was there and actually extended the scan up and extended the scan down. And actually, then they realized that it was there. They actually did it with gadolinium. And so the GAD actually basically, I didn't bring up all the images, but the post-GAD images basically suggested more and more this was not a tumor and it was much more likely to be a disc herniation. It had a lot of rim enhancement and the center part was avascular.
Great. So when we go ahead and tell us what you did, so we all agree with surgery.
Yep. And so most important thing on this one was actually counseling the patients. I had a very long discussion with the patient explaining that, as with most modern medicine, the minute you tell them something, the first thing they do is they're going to go online and search it up. So they go and look up disc herniations. And of course, they're going to find the sports study and all these things. And I told them, this is not a normal disc herniation. So the vast majority of them, you move the dura out of the way. The dura is your containment. It helps you move the nerve roots. Obviously, the biggest issue here is that in some ways, this is extremely difficult because it's a combination of right at the bottom part of the conus, but also you also are in the middle of the cauda equina. So every single one of the nerve roots is going to be right in the way. If you look very closely, they're actually nerve roots right along the wall, right over there. If you follow them up, you'll see these nerve roots get displaced off to the side and they return right there. So the first thing I counseled them is that it was going to be a much more complicated recovery. My plan was basically to do a laminectomy and then using microsurgical techniques to just free up that piece from every single nerve root. Because we were going to be operating at the conus, I did tell them we were going to be doing neuromonitoring. So we were doing SSEPs, motor rope potentials, and really focusing on making sure we had perirectal and anal leads. So I actually knew about this case in advance, and I was talking to Jens about it beforehand because it's kind of an interesting case. And Jens was very adamant. He says, make sure you get lots of good pictures. I said, okay. So I decided to sort of take it as a stepwise. This is sort of the beginning parts. So this was an image basically at the very beginning. You're just basically showing just what the spine looked like after I did the exposure. The key part of doing any intradural tumor and any intradural is just make sure you have a really, really dry field, because the minute you start deflating the dura, all the epidural veins are going to bleed like crazy. So you just make sure you have very, very nice clean. And then I wasn't going to scamp, so I actually did a 2-level full laminectomy, extending T12 all the way down to Ed1. So I removed everything out. There's the outer border of the dura. And at that point, once we had a nice exposure, we then did simple durotomy. I used 6 stay sutures, so 2, 4, and there's 2 at the bottom. And this is me cutting the dura very gently with the knife on the outer side. And this is applying one of the stay sutures down at the bottom to hold it. I put patties on both sides to make sure I keep the field nice and dry. And you can see the arachnoid right here. Next step after that is then we then cut the arachnoid to get an exposure. And so this is an exposure, and I don't know how well it shows, but right here, this is the disc herniation. These are nerve roots. This is the conus coming down, okay? And then as you can see, the cord going all the way down. We were trying to find out the entire sort of nerve roots and everything. There were about 4 or 5 nerve roots that were being plastered off to the left-hand side. Everything else was being deviated off to the right. And this is the tumor right here, well, the disc. We were sort of at the most caudal aspect was the easiest part to get some of it to free up. So we basically just gently started using our rotund dissectors and just sort of freed it up from all the nerve roots. And of course, every time you found one and we started moving it, we'd start getting some signals. Once we got a little piece of it out, so this is it being freed up over here. You can see we already got one little piece out right here. So we managed to free up and get this out. This, the most cranial aspect, was the most difficult to get out. It was completely adherent to all the nerve roots. And some of the sacral nerve roots were going along the back. And as we were removing part of this, we started losing a little bit of signal on the tibant on the left-hand side. So we went down and we saw there was another nerve root underneath. We just started freeing it up. And then this is the majority of the tumor having been removed. So we did send it for path and they did confirm it was a disc herniation. It wasn't any kind of tumor. So at that point, our much more relaxed, but it looked very much. When we then look down below, you can actually see the hole in the dura on the ventral aspect. It measured about 4 millimeters across. We then fished inside that and we found the extruded fragment that was extradural. We removed that one as well. Of interest, as we were going over here, we did actually start exploring on the right-hand side, and we found that some of the disc had actually gone around the back side of the conus. So we did have to move the conus over a little bit over to the other side to find the other fragment that was over here. And then at the end, this is what it looks like. So as you can see, tumor's been removed here. We've had disc has been removed here. Disc has been removed here. You can see over here, this is the cauda equina. Here he's got the conus over here. Everything's been removed on that side. And that is exploring. You can actually see the rent. So the Penfield at this point is actually in the hole where the disc fragment came out. And you can see this was the nerve root that was giving us a lot of trouble. You can see here is one of the nerve roots that's still plastered against the dura that we just didn't want to fiddle with very much. We did lose a little bit of signal on the left tibant that recovered pretty well by the end of the case. We lost some of the quad signal on the left-hand side. Rectal signals were all normal throughout the entire thing. And SSEPs were normal throughout the case. And then at the very end, we just did a nice, simple running closure of the dura. I then kept her on bed rest for about 36 hours. We had an airtight seal. Postoperatively, her right lower extremity strength was normal. Initially, she had some weakness on her ankle dorsiflexion on the left that almost completely recovered over the next sort of 24 to 48 hours. She still has some weakness on her quads. It's about 1 or a 2 out of 5, so she can't get it against gravity. She is able to walk. She just locks her knee when she walks. And again, based on what we were seeing, she should get full recovery because we saw all the nerves looked fine. And this is probably nerve rather than conus type things. Bowel and bladder function is normal. She was discharged actually to a rehab facility. Believe it or not, she's one of our happiest patients because even though her left leg is weak, she has no pain, like all the pain that was causing it. That was the #1 reason. We did not repair the hole on the ventral side. We were going to try and put some stitches or put a patch on there, but every time we started trying to get near that area, we started having troubles with signal. So we actually decided just to leave it. There is some data showing that you can get a ventral herniation of the conus and nerves. So you always got to be a little bit careful about having things pop out through the hole. But in general, we just kept her down and kept it calm, and I should see her back. She's coming back this week for follow-up.
So thanks for showing this unusual case again. I've probably done about 4 or 5 in 30 years of those. And I'm always impressed with how indolent those patients present with. They have very vague symptoms. This is not like what you'd expect in textbook. My one question is, you didn't do a fusion, did you? And this is thoracolumbar junction. So why not a fusion? Why a fusion? What's your thought in there?
Well, I think part of on this one was number one, if you look back at her film, she has an enormous amount of degeneration. And so if you look over here, she's auto-fused down below. She's actually quite stiff. I think part of the reason this may have happened is that she's so sort of stiff over there. I think the biggest thing I wanted to do is I just wanted to not stress her. So I think part of it is, you know, you can always go back and fuse it later and do something else, but I really don't want to drop her blood pressure. We were keeping her MAPs higher than normal to try and keep cord perfusion up. And I think in something like this, because of the scenario, she was already on the table for, you know, a good 3 hours to do this. I think less is more in her. She's 79 years old, right? She's got other medical issues. She's got the dyspnea. I really didn't want to cause any other problems. So my thinking is we'll probably just leave this. I'll follow her. And at some point, if there's an issue, then we can always do something later.
Fair enough. Bob Hart, fusion, yes, no, wide decompression, 2-level laminectomy, thoracolumbar junction above a degenerative scoli.
Yeah, I don't see a need for a fusion here, really looking at it. Yeah, I mean, plain films obviously help inform that decision, but it does look pretty stiff. And, you know, I think that, yeah, I mean, it's a little ugly, but I think going without a fusion is reasonable as long as you're not violating the facets. And I particularly want to amplify your comment. This is not a disc herniation you find reported in the sport trial. This one definitely does not need a trial of conservative measure.
Tariq, any questions from your end or any thoughts?
Is it kind of a dish syndrome with a hyperostosis, even the vertebrae which are visible at the upper lumbar and the thoracic level, which are there, and they're fairly sharp, in fact. And that might have precipitated some weakness and tear in the dura and precipitated some herniation into the.
Yeah, I mean, we're sort of thinking about all of that. I mean, I think, you know, it is a hypermobile area. She is a little bit off on that side. It's interesting. She didn't recall any specific trauma. This was not like some specific lifting or any kind of injury. I do think there's a little bit of a stress area on that side. I think also she also has a flat back deformity. So I think she's hyperflexing in that area, which will load the discs a lot more. Because if you look, we measured her out. Her lordosis is only about 30 degrees. Her pelvic mismatch runs around 40 degrees, 30 degrees. So if you look at her angle, she has a very, very sharp angle here, which means she's going to be trying to hyper bend back. And so I think part of it is that I think with all of that, she is probably putting a lot of stress above her degeneration.
Rod, about just before the pandemic, I think you and I did an intradural disc herniation. Any thoughts on tips and tricks? I mean, he did a beautiful job dissecting it step by step, but I think we fused ours, right?
Yeah. I mean, they're difficult cases. They're pretty rare. Did you already operate, Alexis? Oh, okay, great. Yeah, wow. Yeah, they're not easy cases.
I think it's beautiful. Thank you for sharing that. That's nicely done. Very helpful. So thank you. Do join us. We have some more cases. Jonathan, you want to come up first? So we have a couple of cervical spine cases. Thank you very much, Alexis. Great to see you here.
Thank you.
Dr. Jonathan Plumer is here. He's one of our fellows. Please introduce yourself and where you're coming from. And
yeah, good morning.
He has an appetizer case, and then we get a little bit more complicated.
Good morning. My name is Jonathan Plummer. I'm from Germany. I'm an orthopedic surgeon from Germany, and here in Seattle, I'm a research fellow at the Seattle and Swedish Neuroscience Institute. So just a second. I'm presenting a case. Sorry. Here it is. Sorry. There it is. I'm presenting a case of a 34-year-old male. He had for posterior back neck pain and bilateral arm pain for 3 years, and also diffuse bilateral arm weakness. He tried chiropractic manipulations and also acupuncture, which helped him, but not significantly. He also is on acetaminophen and hydrocodone on a daily basis and had kind of diffuse weakness in both arms. In his medical history, he also had a surgery for his carpal tunnels because of tingling and numbness in his fingers, and he works as a equipment operator for and working with heavy machines. So his exam showed normal reflexes on the upper extremity, but also positive Babinski sign on both sides, as well as a positive limit sign. And he had sensory deficit on the right upper extremity, especially in the dermatome C5. His X-rays showed kind of loss of the cervical lordosis, but a good alignment. He also got a CT myelogram and also an MRI. The CT myelogram has showed some posterior osteophytes at the level C3 and 4, as well as C5 and 6, with spinal cord compression and also foraminal stenosis on these levels. In addition, his MRI showed disc herniation at the level C3 and 4, as well as C5 and C6. Also with spinal cord compression and nerve root compression on C4 and C6, sorry. So because of his symptoms, we operated on him with a 2-level non-contiguous artificial disc replacement, and he did well after surgery without sensory or motor deficit, and also significant reduction of his pain symptoms.
Why don't we stop for a second, go back to CT myelogram?
Yeah.
In the interest of time, we have to kind of make the discussions fast. So I'll start with you, Alexis, and we have to have a microphone for you. Pass the microphone down. A very active, highly muscular gentleman, former Special Forces operator. He looks like a UFC champ, and he has his own company. And now he has 3-level disease, 4, 5 looks great. 5, 6 pretty significant, and 6, 7 looks spondylotic, but without cord compression. So in the future, Jonathan, can you show us the cross-sectional levels? Just mark them out. But left side shows 3, 4, and the right axial cut is 5, 6, 6, 7 is spondylotic, but no cord compression.
Yep.
So any thoughts how to kind of do an effective neural decompression without changing this man's life by fusing his lower spine?
Well, I think, I don't know if I did it. Doesn't seem.
Is it that way?
Yeah, it might be. No, I would do a 2-level artificial disc. I think the only thing I've been a little bit, I've switched a little bit away and going from the MoBC. I've been doing a little bit more of the M6 because especially on a big muscular guy, the one thing that I've always been a little bit surprised about the MoBC is that the hysteresis loop on the motion, they do have an enormous amount of motion. And on a really active guy, I've had a couple of patients on my 2 levels that complain of sort of that abnormal kind of shift that happens as the center core shifts. And so on a really active guy, I've gone for ones that are just allow for a little bit less, more controlled motion is the only thing. But I totally agree. I would do it. I don't think there's really any other option except an artificial disc. I don't think you can get that decompression done again with the cord compression. So I would have done exactly the same thing. I probably would have just done a slightly different disc only because of his activity. And
I wanted to, but at the time, this was a couple of years ago, we actually have long-term follow-up on him. The insurance company denied me to use my preferred disc, which is a Pro Disc C, which I've done for 18 years now, something like that. So I would have done, my preference would have been a less mobile disc. I've had the same problems with the MoBC, but we did what the insurance company dictated.
I actually have a fluoro image on one of my patients that was complaining of that. And so I actually took her to our surgery center and just did it under fluoro. And you can actually watch her bend. And as she extends backwards, when she bends forward, the level above and below starts bending forward. And then you watch her right at 20 degrees, you can see the core suddenly shifts and you see a flip, and then the 2 mobile discs suddenly move about 10 degrees and then it starts moving. And I've just found that in general, it tends to be active, really active people. The people that tend to be sort of less active seem to be okay. Yeah. But that was one of the reasons that And for me, the only reason I picked that one is that one seems to have the closest hysteresis loop to the natural disc. So that's the only thing.
Can you show the post-up again? Bob, so non-contiguous disease, I am not aware of a lot of publications on that. Any thoughts on motion preservation devices? And we've actually 3-level disease. 6-7 was deemed to be the least clinically offensive, but in a real world, I would have liked to try to put something in there also, but that was clearly prohibited. Any thoughts on non-contiguous disc disease treated with disc replacements, first of all?
Well, I think in some ways it's an ideal indication, right? So if you fused all 3 levels, or even the 2 most symptomatic, as you described, leaving these the intervening discs in between, I think, I don't think we have great data because it's a relatively rare situation, but obviously it's mechanically not what you'd like, and it's also biologically not what you'd like, because the amount of disruption of the anterior ligament, I think it's going to probably put that middle disc on its pathway to degeneration. So I like this indication. I mean, I think all of us would like to have the ability to put in 3 discs. This guy might have been somebody who might have put in 3 discs if we could get approvals for that, but we don't yet have the data, and we don't yet have the insurers on board for that.
Let's see what happened over time. This was 2017, so we have some time.
Yep, he followed up last year after a motor vehicle accident in 2020 and had kind of pain in his neck and his shoulder again, but we did a complete follow-up and workup of his symptoms, and he also got an EMG, and MRI, and CT. The CT and the MRI showed a good placement and also a good neural decompression and no displacement or no loosening. And he also got a workup for his right shoulder, which showed a kind of shoulder impingement. And that's it. Yeah.
So this is just a rare case of a non-contiguous disc, and we had the benefit of like actually now 5-year follow-up after a car crash. And so he is fully back into his real pathology now is a shoulder disruption, but we wanted to be extra careful. He had a pretty high velocity car crash. And so we wanted to make sure that the 6-7 disease didn't progress. And actually what has progressed was the 7-1 disease had progressed, not 6-7. So there's a natural course history there. Alexis, any thoughts on long-term? And we didn't have any HO formation really. I was worried he'd be a bone former. Any thoughts on this? I mean, he's actually doing well from his neck standpoint. We just wanted to be extra careful.
Yeah, I mean, I always, when I'm doing disc replacements, I love artificial disc. I think they're great. I actually tell them the interesting data from the US, which is the #1 user of the artificial disc in the United States is the US military. And so paratroopers, if you look most of the time when 101st Airborne does a drop, you know that they've just done a drop because the next few days, the docs are doing artificial discs for all the people that herniated their discs from the fall. So, and the US military has amazing data, and these are really high level people. They get them back to full military duty, and these things seem to hold up really, really well. And so, and again, if you remember the initial trials, the randomized data, they did them in the goats, right? They compared fusions to artificial discs, and not a single goat damaged their disc, and they actually cracked a couple of the fusions. So I always like to give them the data. Those things kind of encourage people. I think we'll still see the long-term data, but I mean, we've got, even look at the original Prestige, we've got 20, 25-year data on those, and they're holding up very, very well.
All right, great. Thank you, Jonathan. So this was actually a pretty good example. Tariq, whilst we're getting our next case up, do you do disc replacements in Pakistan? And what do you think about
we don't have any disc replacement available, but having said that, I think the option was very right. I think he's done very well. I would have done ACDF in those patients. And to prevent any heterotopic ossification, do you recommend any indomethacin treatment, just a medical treatment for a few weeks or a few days?
Sorry?
And to prevent any heterotopic ossification around the artificial disc, do you recommend any anti-inflammatory drug like indomethacin?
Absolutely. So HO is a big deal, especially in a big guy like him. And this guy is powerful. So we obviously use extreme hemostasis. We use a lot of very carefully applied bone wax during the surgery. So everything gets completely sealed. We disarticulate the oncovertebral joints. You can see that on those scans. that Dr. Plumer showed. And we put patients on indomethacin after surgery. And the main pain management for the first 1.5 days is Toradol. So yes, we're very worried about that. Yes, we quote a 10% incidence of spontaneous ankylosis. Why don't we go ahead with another case so we'll escalate a little bit more. This is Dr. Nathan Pratt.
Nathan Pratt. I am also one of the Swedish fellows, graduate of University of Maryland. I have a relatively quick case here for us today. This is a 52-year-old female who comes to us with a lengthy history of left neck and left upper extremity pain, numbness and tingling in her bilateral fingers, balance issues that have been worsening for at least a year. She's had some worsening bladder incontinence requiring use of a diaper, though it's unclear if this is neurogenic or urologic in nature. She was previously worked up for balance and back pain with the lumbar spine MRI, showing a flat back with no significant stenosis, and had been sent to physical therapy after that. Because of her back pain, she eventually had a dorsal column stimulator placed in 2019. Her history otherwise only significant for a carpal tunnel release in 1992, which she recovered well from. Her numbness tingling at that time had resolved. The only significant thing about her past medical history, she has morbid obesity and diabetes, so her medical condition certainly weighed into her decision-making here. And then otherwise, her history is sort of unremarkable. Her physical examination on presentation to the clinic, she had some weakness distally in her fingers and in her grip, worse on the left than on the right side, but not a significant amount of upper extremity weakness. What she did have was significant hyperreflexia in the upper extremities with mute or absent reflexes down in the lowers. She did have present Hoffman sign and had some clonus in the lower extremities as well. We finally get her an MRI of the C-spine showing significant compression. That's at 3.4, 4.5, and then at 6.7 is certainly the worst levels of her spinal cord compression. Because of the appearance of this, a CT scan is obtained showing, it doesn't show all of it, but she has significant OPLL and OALL actually as well. She's ankylosed really in the front end and the back. Her flexion extension views are next to that. You can see there's essentially no movement at all in her spine. Because of her symptoms, she also had a thoracic and lumbar MRI obtained. So she does have some stenosis at T1011. I believe that's T1011, yeah, from a disc herniation though. With her upper extremity symptoms, clearly her bigger problem right now would be her neck. So no movement on the flex X. He had extensive compression of OPLL and presence of OPLL, OALL. After we were able to optimize her medically, it took a couple of months to get her there because of her obesity, diabetes, pulmonary obstructive sleep apnea. Once optimized medically, she was taken for a C2 to T2 decompression infusion. Postoperatively, she felt great even the day after surgery. Her previous symptoms improved significantly even during her admission and was actually able to be discharged back to home. Her immediate postoperative imaging shows extensive decompression and excellent hardware from C2 all the way down to T2. And we actually have a pretty long-term follow-up. She's about 18 months out now from surgery. She has this marked improvement, essentially normal function right now in her upper and lower extremities. Continues to have some symptoms in her lowers due to her thoracolumbar spondylotic disease, which is being discussed as potential operative stuff in the future, but she's very happy. She's now exercising up to 5 times a week for 30 minutes and 15 to 30 minutes a day, I believe. We don't have a physical exam because this was a virtual visit on her most recent, but she's very happy and doing very well after
So a couple of questions. So for me, the experience with disc replacements has led me to really getting CT scans very readily in the cervical spine. Again, that's my one thing I would have probably done differently in Dr. Falakov's case earlier. I'm not criticizing him here, but I just really like to understand the osteology next to the neural anatomy. because it does influence what I do. And I think most of us have gone away from anterior procedures in OPLL upon recognizing that. For me, this is interesting because, again, the clear pathology is in the front, but we ignored that. My question to Dr. Hart is balance, and with your work in the spine study group, sagittal profile has become such a big deal. And she has a flat lumbar spine. She has some thoracolumbar spondylosis, and here she has a barely neutral neck. Deformity correction in this setting would be a very big deal. We kind of did what we could, but we did not do a full cervical thoracic osteotomy because this is a precarious enough procedure. So any thoughts on deformity correction when you have OPLL and accepting basically some more or less suboptimal sagittal profile?
That's a great question. Very complex case, complex decision-making. I think I would have approached it the way you did in the setting of the severity of the neurologic compromise. I think trying to manage that, and then at the same undertaking, trying to do some sort of a realignment here would be, I won't say foolhardy, but probably not wise. And it doesn't look to me like the cervical and cervical thoracic regions are necessarily the areas of her deformity. So I think getting this behind her, reassessing for maybe a thoracolumbar realignment at a later time, makes the most sense to me.
Tariq, has OPLL become a major clinical burden for your practice as well in Pakistan, or is that something that we're just seeing here?
I think we have OPLL more than what we used to think that it is. We used to think that it's a Japanese disease, but I think it's no more Japanese disease. I think there is a strong association with endocrine problem, as has been told. And I think this gentleman had a very, before that, the geographical pattern of the OPLL is very significant, because if you have a flattish type of OPLL, or if you have a heap type, like a small mountain or small hillock, then those are the sharp areas. They carry a poor prognosis as compared to flat lesions. And in this patient, this had not only OPLL, but also anterior longitudinal ligament is heavily calcified. I just wonder why was, it was instrumented all the way. It could have been just enough to do in the top, and not right up to the cervicothoracic area.
Great point. So next, Dr. Tataran, and I think he has a access problem. So Rod, whilst you're trying to log in, Dr. Tataran, when did you change your practice, or how was the transition happening away from decompressing OPLL from the front towards ignoring whatever's in the front and just lordosing and decompressing and stabilizing from the back?
I mean, honestly, I think I've probably always done it since I practiced. But historically, most neurosurgeons would just do decompression. So I think probably in the last 15 years, I think right when I was finishing residency, people kind of made the flip. I think it was mostly from the Japanese large clinical outcomes data. So,
all right, Dr. Tataran. Yeah.
Jens,
Yeah.
I think why people they are afraid of doing from the front is that in this particular patient, the ALL is anterior longitudinal ligament is heavily calcified. You have to break it down. You have to do corpectomy, maybe 1 or 2 levels. And the second thing is the OPLL bone is very densely adherent to the dura. Even if you shave it off quite nicely, it's still adherent, and the risk of dural leak from the front is, to my mind, is significant. It's difficult to repair the dural leak from the front. And it's easier and much safer to do it from the back and let the the lamina be expanded, and let them provide more breathing space to the dura, and maintaining the ossified fragment in the front, or the ossified bone at the front, so you don't disturb it. Because to me, I think the significant complication occurs when you try to take it off, or when you just bar it off.
I think you raised a couple of good points. So OPLL is an inflammatory process. We know that now. We have genetic markers. We have the protein activators for that identified. And as you said, the dura is eroded. This is why in the previous thoracic disc herniation case, without a question, I would have liked to have a CT scan to understand bony erosion as a part of the disease process. I would have probably changed my surgical plan based on what I see. And again, the overall rate of not only CSF leak, but actually cord deterioration is much higher with anterior surgery. So I think this has almost become a board question now. I don't know how, Dr. Tataran, is this a board question now, what to do for OPLL and whether to go front or back? And the other discovery in terms of if you chose to go from the front disc to thin out that bone and create kind of an island. So using a diamond burr very carefully, just break it up, but not try to remove it. So it kind of allows the dura to float up. I want to just recognize Dr. Harshad Parekh from Mumbai. He asked the question of disc replacement versus fusion. Dr. Tataran, as a young neurosurgical colleague who's about to start in a prestigious center this summer, hopefully, what would you tell a patient who's super active like this ex-military guy in terms of, and you're a very active guy, also you're a wrestler, hockey player. What's the difference of disc replacements versus fusions in a nutshell for the cervical spine?
I mean, the fact that you retain a little bit of motion at the level. So I think were I a high level athlete, I'd probably want to go with a disc replacement, like that or that NHL player who had to switch teams because of it. Yeah, I think just motion preservation, correct?
I mean, Dr. Parekh, my review of the literature, I'm very passionate about that, does show, and I may be biased here, a much lower reoperation rate for disc replacements versus fusions. The comparison is probably unfair because we pre-select the patients for disc replacements way more carefully than for fusion patients. But I think it's a safe bet to state that disc replacements have a much lower reoperation rate if done properly for the right patients than conventional fusions. The rate of adjacent segment disease is still not clear. And in this patient, I was fascinated to see that C7T1 had actually degenerated further, which is 2 levels away, so as a natural course history. The return to work is much faster. And again, that's probably a big other deal. Bob, is that a fair summary of the literature?
Yeah, as far as I understand it, I wouldn't add or take anything back from that. I think it's the superior operation. I think we have very few, as we talked about, that are skipped segments or non-adjacent segments, right? But to me, that makes sense that it's maybe even a better operation in that setting than a fusion in comparison to adjacent segments.
One of my big points has been that I think I've become a better anterior cervical spine surgeon by learning all the details of a good anterior decompression while preserving the end plates. Why don't you take us into your case?
I have 2 cases.
Okay.
I don't have much time. I'll try to present with celerity. This is, the first one is a 58-year-old woman who presented with about a year of pain shooting into her right clavicle and scapula. Over the past couple months, she had experienced a dramatic worsening of her symptoms, including decreased right hand dexterity, progressing to recent falls, presenting a myelopathic type picture. She has a history of a revision of an L5S1 fusion from a surgery that was performed outside of the country, but she was pleased with the results. Her main complaints are neck and arm symptoms. So you can see her exam, intact strength exam, essentially, hyperreflexic right uppers, doesn't have any signs of frank myelopathy on her reflex exam, but progressing to her x-rays.
Wow.
This is her pre-op CT.
So she must have an inflammatory disease.
She must.
Do her hands or ankles or feet show stigmata?
I unfortunately did not meet this patient.
Okay. Hips and knees are normal? Go back to the x-rays.
Yeah. She's non-ambulatory, really. She was in a wheelchair when I saw her in clinic.
Does she have a formal diagnosis of an inflammatory arthropathy?
Not formal. Not formal.
All right. So this is a destructive arthropathy with resorption cysts, reactive sclerosis. obviously deforming subluxation with a complex deformity, so anterolisthesis, a scoliotic tilt, so probably she has a torticollis also. I can't see the facet joints here, which I always like to look at.
Sorry.
But this until proven otherwise, is some form of an inflammatory arthropathy with a reactive osteoarthropathy.
And then proceeding to a preoperative MRI scan. Very tight. So surgical decision, how do you treat?
Yeah, I mean, that's a good question. Tariq, what would you like to do? So we have a complex deformity now with a clear significant cord impingement. The myelopathy looks radiographically far worse than what the exam.
Diabetic?
I'm a little bit surprised.
She's not diabetic.
What's your approach?
She's not diabetic.
She's what?
Diabetes.
Yeah,
No,
Diabetic.
not diabetic.
No, she's not.
diabetic
But I think,
neuropathy is a great
If you
consideration.
look at this CT scan, she had got both impingement from the front and the back, and you have to, I'm afraid you have to go from the front and the back as well. I would go in the back and do the laminectomy and stabilize the situation between C2 and C3-4. And maybe one has to include C1 as well to get a better purchase and provide more stability, and then turn it to the front and realign it and put a bone sort of bony fusion there between C2, remnant of the C3 and 4.
Wait, so
front
you
and
would
back?
do posterior first and then anterior?
I think so. Posterior first and then anterior.
Yeah, we may have a difference of opinions there. Why don't you carry on?
Well, we did it from the front and the back, but just in the opposite order. So stage one was C2, 3, 3, 4, 5, 6 ACDFs. Stage 2, 3 to 7 lamis for decompression, C2 to T2 arthrodesis, and a 3-4 Smith P. This is her post-op imaging, midline showing the ACDFs, parasagittal. She actually had a working rod and she had 3 rods, which I tried to show on translaminar screws up top at C2.
Why'd you use translaminar screws at the top? Did you have arterial dysmorphism?
Yeah, they were extremely difficult to place C2.
So Rod, tell us why you went front first and then back. I mean, this looks obviously very good, but what tipped you off to kind of go front first and then back second?
I mean, I think you could do either. I just have I prefer to try to get as much lordosis as I can. I think if you go from the back, you kind of lock them in.
Yeah.
And then we really are careful about trying to just stay within the disc space. And fortunately, we were able to get good correction.
I think doing the 3-level anterior release and actually ignoring that ankylosing segment was quite brilliant because once you have 3 levels released, it usually gives you far greater leeway. And the other really insightful move was that you did not do an anterior plate, but relied on very good decompression carpentry and release, and then just trusted your posterior hardware. That's were those your thoughts or?
Yeah, I mean, we tried to get, I think going from the front also, I think you're able to lengthen the spine and get good lordosis rather than shortening it. So that's exactly what we did, Jens.
Did you get post-op x-rays?
No post-op x-rays as of yet. This was done pretty recently, so I don't think she's followed up in clinic yet.
Coronal imbalance, was that corrected?
Corrected very well. If you look at I tried to show it on the right 2 pictures. Yeah. So she's pretty straight there, but then looking pre-op, she's bent a little bit off to the side.
That's really nice. So Tariq,
what kind of graft did you put in? Is it fibrillar or some
structural allograft?
So these are pre-manufactured.
Machined allograft.
Companies make allografts here, and these
machined
are allografts.
Yeah.
And they're size matched, and we have nice tools for that. Dr. Hart, multi-rods for the subaxial reconstruction. This is a pet peeve of yours now. What's the purpose, and why is this such a good case for this?
Well, if by pet peeve you mean my favorite operation, then we can still agree. I think this setting with this amount of deformity and, I think an extra rod here makes sense. I tend to do them as outrigger rods attached to the primary rods, but I wouldn't argue with something like this, what I would call a satellite rod looks like. I think this just looks very nicely done. I would have done it in a similar staging. Looking at it, I was thinking that the 3-4 disc, I wouldn't know that. I don't think I would have trusted myself to have gotten the distraction you were able to get here, Rod, and I may have done it as a vertebrectomy rather than a discectomy, but clearly this worked. And in doing it as a vertebrectomy, I suspect I would have done it in 3 stages, front, back, front, and put the graft in last. And certainly agree and underline the ability to avoid anterior instrumentation here, particularly in the upper cervical spine, where it can really cause swallowing issues. I think is key, and the posterior instrumentation is plenty strong to allow that.
That's really nicely done. So thanks for sharing that. How's the swallowing?
As per the notes, good.
Awesome. Nice. And you have one more patient? Yeah.
Yeah. So this is a patient who actually had their surgery yesterday. This is a delightful 68-year-old ex-Morse code decoder for the Army, who presented with about a year of progressively worsening neck pain and then 2 months of frank myelopathy with diminished balance, frequent falls, upper extremity clumsiness, hand weakness. His left hand was a lot weaker than the right. We saw him in clinic. So you see his exam there. His grip was 3s on his left side and diminished on the right. He had diminished upper extremity reflexes, heightened lower extremity reflexes, 8 to 12 beats of clonus bilaterally, brisk clonus, toes are up bilaterally.
Can you just share the NURIC score and the MDOA? We put them in the chart.
I don't have the MGOA, but I would say he's in
the MGOA was 8. There's a sheet. I put that in.
Oh, sorry, I didn't
MGOA 8 is 8. Normal would be 13 to 15, depending on which scale you use.
And NERC probably 3.
He was a 3 to 4. That's one of those boundary cases. He's very gait impaired, but he can still walk. He does not use ambulatory aids. So I think it's important, as we will hear undoubtedly, that we kind of grade myelopathy, also try to grade it. Interesting, his urodynamics were pretty normal.
So preoperative MRI, we actually just saw him with a cervical spine MRI, which showed a serpiginous cord course and multi-level spinal stenosis. And then at the caudal end of the sagittals on the left, we noticed big disc bulges at 1, 2. So proceeded to get a thoracic MRI prior to planning surgery, which showed continued levels of spondylosis and disc herniations and possible cord compression. So initially we're planning on doing a limited cervico-thoracic decompression fusion, but then upon viewing the thoracic spine, decided to extend it further. Any thoughts as to how people would treat this?
So Rod, so here, this patient has upper thoracic spondylosis. We do not have standing full length films. There's a CT which shows hypertrophic osteophytes, but no OPLL. We couldn't download this right now because the outside very unusual image system. But assume that there's no OPLL, but he has kind of a kyphotic neck. He has a kyphotic upper thoracic spine, multi-level spondylosis, severe smoker.
Yeah.
Thoughts?
I mean, I think I probably would do similar to the case that I showed.
So front and back?
Front and back. The only question on this one is how many levels do you do from the front and then how far do you go down? Because I think these are cases where, if you end it too high, then you can get PJK. And just based on the MRI, it looks like there's significant cervical thoracic kyphosis. And then with the myelopathy and the loss of cervical lordosis, I think you're at high risk for PJK.
Dr. Abdul Jabbar, can you unmute yourself? My partner, Amir Abdul Jabbar, is over in one of our other hospitals. Amir, this is obviously one of those kind of problem cases. We now know that there's upper thoracic spondylosis. It's very hard to sort out. It's probably not contributory to the significant cervical spondylotic myelopathy. But how high, how low do you go? What are your thoughts in terms of doing the front and back? And would you go C2 to thoracic something? So share your thoughts with us.
Oh God. Can you still hear me? I'm wondering.
Yes, we can't see you, but we can hear you.
Okay. So I think, when you're doing a kind of larger correction and multi-level anterior, obviously you want to get good control, both proximal and distal, with the posterior construct to really accentuate that curvature correction. In this case, it would be creating lordosis. It's kind of hard for me to tell just from the images, the limited images we saw, but obviously you want to get both above and below the pathology. If I'm doing an anterior posterior procedure, I would say, C2 to T2 is pretty standard. But if there's more distal pathology, going further down to the thoracic spine is totally reasonable. And like Rod mentioned earlier, you do want to prevent DJK. I don't know that there's any kind of tried and true method to improve someone's kind of protoplasm. I think that's a big part of it, but you do want to get to a stable level distally.
So traditionally, where would we anchor caudally if we look at, if you assume he has a normal thoracic apex at around T6? Would you go below that? Would you go all the way?
I was thinking C2 to T2, if I'm doing a front back, is pretty standard. If I'm doing a large anterior multi-level correction, I do want to get down to the thoracic spine, at least, in some limited cases, maybe T1, but C2 to T2 is pretty common in my practice.
All right. Why don't you show us what we did?
So this was yesterday. So we did it all from the back, actually. We did C2 to T7 posterior instrumented fusion with lames from C3 to T1. You can see the AP localization technique of a screen on the left, followed by the hardware AP intra-op shots, AP lateral. Surgery was uncomplicated, went swimmingly. And here's post-op imaging from last night. No x-rays yet.
Jens, just out of curiosity, why didn't you go from the front?
We actually, what Zach didn't show, but that's no criticism, was we actually got flexion extension films and he corrected interlordosis very nicely. So he actually is one of those cases of an acquired kyphosis where he walks around like this to give himself indirect neural decompression. So, and he is a smoker, so your point is a very good one. We did use off-label bone morphogenic protein, and we did a very aggressive facet decortication at all levels, literally almost like a Ponte. We actually took some images of showing how deep the burr went into the facet joints. Obviously being very careful with the vertebral artery, but with modern hardware, these are 4055 rods. This is a dual core system. We're actually very pleased to get a very substantial correction. We did it like what you taught me with GW tongs and high weights, and then reduce those as we basically put the rods in. Bob, we went down to T7 to get below the thoracic apex. Is that enough? Was that over aggressive? What are your thoughts?
I would like to see long cassette films, but that's probably far enough. I mean, it's really equivocal to know where to stop, I think, and there again, it's really hard to make a data-based statement. This alignment looks very nice. I think you got great correction, and looks like you got the job done. I probably would have done this front back, but maybe seeing the flexion extension fuse would have changed that opinion as well. But it looked to me, as I was looking at it, I was thinking that would be the needed approach. So I appreciate you were able to get it without going in front. That's great.
All right, Tariq, any comments? Otherwise, I'll be glad to introduce you.
I think it's very well done. But my question is, would you have thought about adding an osteotomy at the cervico-thoracic junction? And second is, to better purchase, these are pedicle screws, I believe. They are
yes,
not lateral mass
pedicle screws, and we have thoracic pedicle screws. We did simple lateral mass screws. Again, the decision-making not to go from the front and to do it all from the back was entirely hinged upon the flexion extension films. He did get Lermite symptoms when he hyperextended. So he literally tried to get neural decompression just by holding his neck forward tilted. And again, in terms of the cervical thoracic osteotomy, again, I call it like a Ponte almost. We literally resect the lateral mass of C7 very aggressively with a Midas to tilt the head back. And we use a dual core rod system. We anchor it in the subaxial spine first, and then bring the head back. And we use dynamic traction, like what Dr. Skuyan introduced me to. I would have traditionally done with a rigid carbon Mayfield, but and then readjust the head up. But I think this dynamic system that Rod showed me is way better because you can really play with the neck more. Bob?
I was just going to ask you to describe that. Has it got Gardner-Wells tongs or is
GW tongs, simple GW tongs. You
So
play with the alignment.
it's
and the weights.
dual vector traction?
No, single vector.
Do you
and then
use
remove
the
weight.
extension?
Just we look at how and what we need to do, but single vector, but just disengaging it, and this mobility is actually very nice. You can then reduce the weight as you're pulling the neck back.
And do you grab the Gardner-Wells tongs then through the drapes and extend them?
You can if you need to,
yeah.
but in this case, it was actually not necessary. It just came back beautifully. The hardware now is so rigid. 4mm 5.5 rods are so rigid that once you have the subaxial spine with multi-point fixation anchored, you can actually literally pivot the head up. Rod?
I actually learned this in New Zealand because when I did my fellowship there, we never pinned any of the craniotomies. And to me, it was like, it was unbelievable because you could do the craniotomy, clip the aneurysm, then turn the head back. And then we did it, all of us attendings did it in spine surgery too. So it's a game changer.
Great. Let's go to our main speaker, Professor Tariq Sohail, as an orthopedic surgeon at Doctors Hospital in Lahore, Pakistan. He is a graduate of the King Edward Medical College in Lahore and Liverpool University, Royal College of Surgeons, Edinburgh, Glasgow. And he is a well-respected member of the AO community as well. And he's the current president of the Pakistan Spine Society. I've had the great honor of lecturing with him and his team on a couple of occasions. And we've seen a couple of cases this morning that show the bandwidth of cervical, we also had a thoracic case, myelopathy. So I'm very curious to hear his thoughts as to myelopathy detection and treatment. Thank you for joining us this morning, Tariq, and thank you for your comments. All right. Can we share a screen?
I got it, sir.
Thank you very much, Jens. It's a great honor to work with you, to be with you in at your platform of Seattle Science Foundation. It is always a great pleasure to hear you in your participation and contributing to our knowledge, and at the same time giving me opportunity to talk on your platform and your forum. This OPLL degeneration and the laminoplasty to treat all these things, it's not something, it never used to be very popular sort of theme of practice, but I think over the last few years, it has become more sort of being recognized and being treated both medically and surgically. And since, as I said earlier, the OPLL, we used to think it's a Japanese disease, but I think it's much more sort of being prevalent here. And I think, I believe that if your mind knows, your eyes will see. If you do not know, and if you're not aware of this problem, then you will not recognize it. And so I think we are seeing more and more patients of OPLL with the endocrine issues, and we are dealing with it. Cervical spondylosis, the degenerative process, is quite common with the age of 45, 50, and there is a degeneration of various facet joint, oncovertebral joint with a disc degeneration, which presents with axial pain, radical symptoms, pain and paresthesia, or occasional motor weakness as the disease becomes progressive and impinges on the spinal cord and the nerve root, which are, it's a mainly compressive myelopathy in which there is a dynamic and the static compression both to the neural tissue when they exit foramen or in the central part of dural sac, and that produces various kind of issues. If you look at the normal spine posture, normally is a lordosis. Then if you have a neutral, then you have a straight K line, and then you have a kyphosis, and then occasionally in certain disorders Like rheumatoid arthritis, there is a sigmoid, there is both extension and flexion in the same spinal segment. It all depends kind of pathology, whether it's just a degeneration or it's just degeneration secondary to some inflammatory disorders like rheumatoid arthritis, which is not uncommon in our society. And you can have a various. With this, normal lordosis will accommodate this cord very comfortably, and they will be normal function. But as you go from a normal to the neutral to the kyphosis, the dural sac or the cord becomes stretched over the kyphotic segment and start dysfunctioning it. And with the sigmoid, you have a various sort of patterns of neurological involvement depending on the type of impingement and the degree of impingement in those conditions. This is this is normal what you see in you have a cervical spondylotic myelopathy because of degenerative changes. There may be spondylosis, there may be deformity, or there may be some other instabilities there at the various levels because of degeneration, because of inflammatory disorders. OPLL, as I said, this is becoming more and more being recognized and appreciated, and it is being treated. And then ossification ligamentum flavum because of hypertrophy of the capsule of the capsule and the ligamentum flavum at the back. It is not uncommon. We have seen a couple of patients who have not only OPLL but also OFL, ossification ligamentum in tandem, and that's a very poor combination because I have seen only 2 patients. They present with the rapidly progressing neurological issues, and if you have to treat them, you treat them both front and the back in way of decompression and stabilization. Then there are other conditions like Ehlers-Danlos loss and Klippel-Feil syndrome, which presents with the various pathologies, which may be genetically driven. And if you look at the pathophysiological point of view, there is static factors, which are compression, ischemia, there may be dynamic compression, and there may be some sort of impingement of the neural tissue. There may be a sort of CSF flow is sort of disrupted, and that puts further impairment in the nutrition of the neural tissue. There may be axial tension, and there may be inflammation and ischemia, and there may be hyperexcitatory element to it. And then these patients, they present with various pains, paresthesias, or frank motor or sensory deficit and paralysis, depending on the pathology which they go in. And on top of that, if they have any trauma, that precipitates neurological catastrophe. There's certain genetic elements like Klippel-Feil syndrome, trisomy 21, and Ehlers-Danlos loss, which are basically, these two are hyperlaxity syndrome. They may present with a earlier problem with a, sort of hyperinstability, hyperlaxity and instability, and subsequent they are run into the sort of neurological impairment if they have any trauma. This spondylosis, there may be quite sort of number of patients which are more have immediate relative, they have a more prevalence. This may be because of the collagen disorder or the collagen being not normal. And these patients, they have not only spondylosis in cervical spine, they also have lumbar spine problems, and vice versa. If they have lumbar spine problem, and if they have some element of upper neurological problem, upper motor neuron problems, or the paresthesias or pain in the upper limb, then I think they should be sort of checked into the cervical spine as well, because the cervical and lumbar spine problem, they go hand in hand in certain number of patients, especially with the genetic predilection and collagen problems. OPLL, it used to be Japanese disease, but I think we see it not very often, still see it quite often. And they are a patient, it is again genetically determined because there is increased number of patients in their immediate relatives or the other relatives in their family. And there have been various genetic risk factors like VDR, collagen 9, or ApoE. These are the various genetic markers which present. Similarly, in the OPL, there are other COLA6A and NPS, and there are other sort of genes, the alleles which present, and they put the patient at risk in developing these conditions. If you look at the pathway of there is a chronic compression, there is ischemia, there may be inflammation, there is a CSF flow is distorted, and it further increases the risk of ischemia. There's a venous congestion, and that produces a microglial or T cell infiltration that results into various enzyme activity, and that results into apoptosis, the slow death of the glial tissue, neural tissue, and that is replaced by the gliosis, and that presents with a various degree of myelopathy. You can pick it clinically, and you can demonstrate it with the MR examination, and that is feasible. The Japanese, they have a modified Japanese orthopedic score, which depends on the examination in the upper limb, lower limb, and the sensory dysfunction in both extremities. And from scores, mild to moderate, between 12 and 14 is a moderate one, and the mild one is 15 and 17, and the severe is below 13 or 14, and that carries significance because mild and moderate, you can treat them for the time being. You can observe them and see how they behave, and then if they deteriorate rapidly or the neurological problem occurs in rapid sort of fashion, then you can go for surgery. If you look at the natural history, there is a stepwise decrease in function, and there is time of period of good period, and gradually it's a downhill deterioration, and there's a good time in between. So you can observe them for the timing, but as they deteriorate, you can intervene and see whether they need surgery or not. And if they're deteriorating rapidly, then I think surgical consideration is the recommended procedure. You can treat them non-surgical ways under supervised trial of structure rehabilitation, etc. And if they have a mild degenerative cervical myelopathy, but subsequent to neurological deterioration or failure to improve with a physical therapy rehabilitation procedure, then you can go for operative intervention. In our society, the people, they are afraid of surgery, so you have to counsel them. You have to continuously observe them and see them whether they're going from bad to worse or whatever. If they present with the situation where they have a moderate degree of myelopathy or the involvement of the neural tissue, then surgical intervention is required. And the severe cases, when they have a imbalance, they cannot walk, and they have a lot of spasticity, their gait is abnormal, they cannot have good hand function, then I think surgery is indicated. And surgery does not always improve a lot to the normal level, but I think it does improve to a level where they can gain much more functional ability, and they become less dependent on their relatives, and they can function in a more sort of coherent way. There are certain drugs. Riluzole is important, which is glutamate blocker. Sodium and glutamate blocker enhances function outcome in the patient undergoing surgery. So I think this is one drug which protects this neural tissue, and it improves the outcome in those patients who are having degenerative cervical myelopathy, and I think it should be equally protective in other conditions in like OPLL and other situations which result in myelopathic changes in the cord. Preoperative planning is always better to have an X-ray, AP, lateral, and flexion extension, because in cervical spondylosis, there's maybe a combination, whether there's one level, two level, there may be a instability on one level and stenosis at the level above and below. And in those situations, one has to stabilize both front and decompress at the back. You need a 3D CT scan. You need to have an MRI, which gives you the level and extent of the compression, whether the myelomalacia is there, and the very typical snake eye appearance, which appears in a cross section. This is an axial T2 image which shows cystic necrosis due to mechanical compression and the venous infarct, which I said earlier, that the persistent changes, compression, dynamic or static, and CSF irregularity, flow irregularity will result into venous infarct, and that will present as a snake eye appearance. And when you have a cystic necrosis in the center of the near center of the cord, and it appears that it's a snake eye kind of thing. I think it's if you see the myelomalacia with this snake eye appearance, is poor prognostic indicator, but nevertheless, one still need to improve the situation. One need to decompress and stabilize it so that the patient can have as much as improvement as possible. Then there are other MRI, these are the Michael Felling's slides, which I borrowed from him. And I think he has done multi-parametric quantitative MRI, which shows the different sort of area, whether there's axonal injuries there's a demyelination and gliosis, and there is sort of a ratio between gray and white matter. And these are new sort of MRI sort of findings of the parameters, which are indicative of extent of the damage and a kind of a prognosis, which you can tell the patient in the view of these new multiparametric quantitative MR examinations. This T2 star weighted images, which shows the ratio of white and gray matter that reflects various pathological processes like demyelination, gliosis, and other changes. And it will tell the amount of tissue damage in that area, and they tell you indirectly the prognostic element in these patients who present with myelopathic changes. Surgical treatment, you can have a various anterior cervical discectomy and fusion or arthroplasty. This is only limited to 1 or 2 level cord compression, secondary degeneration, or the prolapsed intervertebral disc, in which produces focal canal canal stenosis. You can have ACDF, which may be 1 or 2 levels or 3 levels, multi-level degeneration, especially with a kyphotic deformation, in which you think with a kyphosis, the cord will be stretched over the kyphotic segment, and it will add to the damage in these patients. So you have to correct the sagittal balance. You have to correct the posture of the cervical spine and bring it back to lordosis, or at least to the neutral level. Then you can have a laminectomy plus minus fusion in a multi-level compression with axial pain and facet arthropathy, and laminoplasty, which is, I think, much easier, simpler, and better operation for multi-level degeneration with the myelopathic changes in the cord. Arthroplasty, arthrodesis for myelopathy in 1 level gives you equally good results. So you can have it. We don't have any facility, the provision by the vendors for the cervical disc, but nevertheless, I think ACDF plus minus decompression of the back is equally good. In 2 level, you can use ACDF, and you can put a bone graft or fibular graft from the iliac crest, or machine allograft. We don't have a machine allograft, but we do have allograft, which is as a bone block, and you can use iliac crest as a tricortical graft, which is good in all terms, in terms of osteoconductivity, osteoinductivity, and at the same time providing cellularity. And you can protect the graft and provide fusion and restore the mechanics by the interior plating. If you're using any cages, which you can use like PEEK cages, they must be nowadays coated with a hydroxyapatite, or you can use titanium cages, which are again bio-friendly and provide early additions to the host bone. Laminectomy is ideal for a single level disease, or in a dish in which just 1 or 2 level problem, and the spine is still lordotic, and you can have a C to 7 SVA, which is less than 30. That means it's not in a kyphotic element, and it is restricted in 1 to level between C3 to 6 level. And I think this is the contraindication for surgery, anterior surgery. The idea is you should leave the cervical spine in from the kyphosis to the neutral position or to the lordotic position, because in a kyphotic situation, the caudal cord is stretched over the osteophytes, over the extent of the cervical spine. But if you restore them by the anterior surgery, you can let the cord fall away from the osteophytes and other bulges in the back, and at the same time, the second stage, you need to put a decompression from the back, and that will allow the cord to breathe more happily and just get some function back in a myelopathic situation. Laminoplasty is easy, and I think it's a Japanese procedure which have been described by Hirabayashi in 70s. There are various procedures in which you expand the spinal canal by doing a single door, double door, or selective, skip laminectomy, or various other step cut osteotomies of these laminae, which you can do it. The idea is to expand this cervical canal so that the cord can push itself back and have more space to breathe, and get the functional restoration with a more physical space available after all these procedures. It preserves all the motion. Patient do well these kind of procedures. There's a decreased operative time and hospital stay. There's no issue of pseudoarthrosis, and the expectation from the patient for the neck pain is minimum, and reoperation rate is minimized because there is not very much issues like pseudoarthrosis or CSF leak or some other problems. And the only problem sometimes is that at the top and bottom, they may get some scarring, and they may have a kind of boomerang phenomena in which scar forms at the level of where the normal to the laminoplasty level is being. But I think that can be overcome by providing more space by undercutting the lamina at the top and bottom, and provides a sort of smooth transition rather than a sharp transition in those areas. The indications usually ossification posterior ligament, congenital stenosis, and if you have a congenital stenosis, then any degeneration will precipitate stenosis at the early age, and whether it's OPLL or degeneration which comes with age, or hyper mobile cervical spine, or in a patient who is who uses his neck quite vigorously. Multi-level spondylosis and multi-level herniation nucleus pulposus. I think these are indications for surgery. The contraindication is severe neck pain, because there is neck pain not only generating from the disc, but also from the secondary changes in the facet joint. So you have to consider all these elements in the way of MRI and CT scan. And if you have a kyphosis, then you have to consider that you have to restore both from the front or from the back. In those situations, just a laminoplasty at the back will not restore the posture, and it will not restore the function fully. And if you have a SVA more than 35, and if you have an occupying ratio of the neural tissue, the cord into the ratio, that means if you have a stenosis or there's a small space for the cord to be occupied, then you have to increase the space, and you have to go, and stabilize the spine by anteriorly and put a sort of stabilizing procedure. I think it has advantage over the anterior procedure. It is motion preserving. There's no pseudoarthrosis risk, and the dysphagia and the dysphonia, which is not uncommon in the anterior ACDF procedure. It is minimized, and the graft extrusion risk is not there, because there's no graft to be used in this situation like you use in ACDF. Laminectomy fusion, I think it is a good procedure. You can use multi-level laminectomy, and at the same time you provide fusion at the same time by putting a pedicle screws and some stability, and you can same time you can correct the posture as well. Anterior and posterior, you can do both levels. If you have a multi-level disease, if you have a pseudoarthrosis, risk is there in the anterior one, then in the posterior, the risk is minimized. Increased risk for graft extrusion is much less as in the posterior approach, and there is a less trauma in the posterior one. And if you have a focal instability, then I think you should go for the front, and then in the back, I'll show you the cases. And in revision situation, then you can go front and the back at the same time. Or if you have a deformity like a DHS or some other deformity or multi-level OPL, then you have to plan anterior and procedure, or posterior to anterior, depending on the situation in this patient is presents. And the
Hey, Sohail, sorry, we'll have to come to a close. Can you kind of
sure.
conclude? Thank you.
Sure. Okay. This is one patient who had a flexion deformity. You can see there is instability there, and this has been treated both anterior fusion and subsequent sort of posterior laminoplasty, which is expensive one, using small plate. And this is how we do C2 T1 exposure, and they preserve the C2 muscle attachment because they provide stability in the occipital area. Trough location is important. It has to be a junction of the lamina and the lateral mass. Which side to open, it depends on the degree of compression, stenosis, and presence of radicular pain, and the handiness of the surgeon as well. This is how we did it, and this is a lateral gutter on one side, gutter on both sides, and which one is open on one on the right side, and then you stabilize it. It is important to realize the laminar anatomy varies from top to bottom, and also the ligament of flavum, which is important factor. Once a bone is thinned out, you should complete the trough by curettes and fine carisons, and open it side is, if it's not complete, there's maybe difficulty in elevating the hinge. So you have to thin it out so that it just breaks up with just a gentle pressure there. And you have to maintain the integrity of the ligament of flavum because it provides stability and sort of opening of the laminae in those areas. This is the various, you can see the cord is being, it's already decompressed and being stabilized. And you can use the open door with either with a suture or with a small plate, which is used. Occasionally, you have to put a graft and rib or some other material or hydroxy spacer to keep the door open. You can use either single door or double door, and you can close it over the drains. But we do in a different procedure nowadays. We use a Kurokawa procedure, which has modification. We open both sides of the laminae, but we don't use any hydroxyapatite blocks or anything. We use same sort of spinous process, which we cut it out, and you can turn it on side and stabilize it with the suture, and that acts as a graft and provides expensive element to the laminoplasty. There is a gutter on either side, and there's a spinous process is used as a spacer. It is stabilized with the suture. It is inexpensive because you don't use any plates or bone graft material. This is OPLL, quite extensive one. And this is once it has been opened up on the right side, you can see the spinous process, which we have cut it out. They have been turned on its own, and they have been stabilized with a laminoplasty sort of hinges, and the spinal process, they act as a spacer in the center, and there's no problem with the fusion because it's all sort of corticocancellous bone of the spinous process, which is good bone and heals quite nicely. This is a close-up procedure, close-up of the procedure. You can see these sutures, they are good one, and they provide good amount of stability, and it provides a good expensive sort of this is precautions.
Tariq, sorry, we'll have to come.
Just one more slide. Okay. This is a post-op soft collar headrest elevation for 30 to 45 degrees to reduce out of bed for first postoperative day. You remove the drain 24 to 48 hours, and then you convert to soft collar, and then review in 6 weeks. These are complications. And these are the various factors which sort of influence the outcome in these patients, which is a patient selection, degree of cord compression, and any root compression or cervical alignment and the instability if it's there, and the host factors and comorbid conditions. So I think what we are doing nowadays is not open door or double door. We're doing double door, but we're using same spinous processes which have been turned on its side, and we use it as a graft, and it's a modification of Kurokawa laminoplasty, and it works very well. And we don't use any ceramic material or ceramic blocks which have been described as a Kurokawa. We use spinous processes, and it is inexpensive, and it works as well as bone graft or some ceramic material spacers in those situations. Thank you very much, Jens, for bearing with me for extra time.
Oh, thank you. Sorry to rush you, but we have a feed otherwise. So one quick question due to time constraints. OPLL on laminoplasty, is that a good idea or bad idea? Because the Japanese say that the OPLL progresses if you don't do a fusion.
Well, I think if you're doing a laminoplasty, and if you, I mean, we don't add any fusion unless there is a, if it's a continuous one, then I think you don't have to fusion. But if you have a segmental one, in which or a combined one in which you have a smaller segments of continuous area, and then the small areas of OPLL, in those situations, yes, I think fusion through the posterior approach can add to the stability and add to the sort of hardy progression of OPLL formation. But I think if it's we restrict ourselves to the stenotic area or the area which is sort of OPLL mass is there. I mean, that serves a purpose most of the time.
It's a very interesting perspective. I encourage you to show us outcome studies, maybe also some post-op CTs of 2 years with this kind of an autologous bone graft laminoplasty. It's certainly an interesting idea. And obviously would be a great cost saving, but it's certainly a nice technique. I really liked your imaging thoughts, and I think one of the basic things that we all need to preach to our medical community around the world is being far more aware of myelopathy and understanding myelopathy, and without overdiagnosing it, recognizing it, and at least following patients and informing them. I think there's a huge gap, and I'm still just amazed how patients in all of our medical communities can develop this very serious problem and be completely neglected for a long time.
Yeah, I agree. I think the more and more realization is there that OPLL is there, spondylotic changes producing myelopathy, they are there, and there's some MR changes in those. They may be subtle in the to pick up in the regular MRI, but I think these changes, if the radiologists know, they can modify their techniques and they can pick it up.
Yeah, and teaching our medical students more about proper neurologic experience. That's my pet peeve. We have to close. Thank you, Tariq. All
Thank you.
Good comments and very insightful. We enjoy our collaboration with you very much and your colleagues. So take care.
Thank you very much. Thank
Bye-bye.
you. Next session, I think one of our guys will be presenting their cases.
All right. Take care. Bye-bye.
Thank you. Thank you.
Is the feed off? Ben, is the feed off? Ben, are we off? So again, this